Welcome to this overview of an open appendectomy, one of the most common emergency abdominal procedures. In this video, we'll walk through each step of the surgery, what instruments are typically used, and key details every learner should know. Step 1. Positioning and preparation. The patient is placed supine under general anesthesia. The right lower quadrant is prepped and draped in sterile fashion. The incision is made over McBurney's point, located 1/3 of the way between the anterior superior iliac spine and the umbilicus. Step 2. Skin incision. A small oblique incision is made over McBurney's point using a number 10 blade. Skin and subcutaneous tissues are divided with the scalpel and extended as needed using Metzenbaum scissors for deeper tissue. Make sure to incise through Camper's and Scarpa's fascia separately to maintain anatomical planes and reduce postoperative seroma. Step 3. Dissection through muscle layers. The external oblique aponeurosis is opened in line with the incision, using Metzenbaum or Mayo scissors, and the underlying muscle layers, the internal oblique and the transversus abdominis, are bluntly separated with Kelly clamps or a finger sweep. Take care to avoid injury to the iliohypogastric and ilioinguinal nerves, which may run just medial to the incision. Step 4. Entering the peritoneum. The transversalis fascia and peritoneum are gently lifted with hemostats and incised sharply using Metzenbaum scissors under direct vision. This step should be done cautiously to avoid injury to underlying bowel. Step 5. Locating the appendix. The cecum is located first, often easily identified by the presence of Taenia coli, which converge at the base of the appendix. Use Babcock clamps or DeBakey forceps to gently grasp and deliver the appendix into the wound. Avoid using traumatic forceps, which can crush the tissue and lead to perforation. Step 6. Dividing the mesoappendix. The mesoappendix contains the appendiceal artery, a branch of the ileocolic artery. Using curved Kelly clamps or tonsil clamps, small segments of mesoappendix are clamped, divided, and ligated with 2/0 or 3/0 silk ties. Alternatively, the entire mesoappendix can be divided using electrocautery and ligated en bloc, depending on the surgeon's preference. A common pitfall at this step is inadequate control of the artery, which can result in bleeding. Step 7. Ligation and removal. A cryol clamp is placed at the base of the appendix. A 0 or 2/0 silk tie is placed at the base, just distal to the clamp. The appendix is then divided between the clamp and tie using scissors or a scalpel. In some cases, a purse string suture is used to invert the stump, but this is optional in uncomplicated cases. Be sure not to leave a long stump, as this can lead to stump appendicitis. Step 8. Irrigation and inspection. The stump is inspected for bleeding or leakage. The peritoneal cavity is irrigated with warm saline, especially if there has been perforation. A suction device or bulb syringe is used to remove debris or contaminated fluid. Step 9. Closure. The peritoneum and muscle layers are reapproximated with absorbable sutures, using a Mayo needle holder. The external oblique is closed with interrupted or running sutures. The subcutaneous tissue is irrigated, and the skin is closed with staples, or 4/0 nylon sutures. In contaminated cases, the skin may be left open to heal by secondary intention. Final step. Dressing and recovery. A sterile dressing is applied. The patient is awakened from anesthesia and extubated. Postoperative monitoring includes signs of infection, pain control, and early ambulation. An open appendectomy is one of the first operations many surgical trainees learn. Knowing the steps, the anatomy, and the instruments involved builds a strong foundation for safe surgical practice. Thanks for watching.